Yeah,
screen.
yeah, yeah.
All right. The title of the presentation is Measuring the Inter-Rater Reliability of the Pediatric Appendicitis Grade. And you know who I am now, thanks to Dan's generous introduction. I'll get started. So, many of you know that appendicitis is the most common pediatric abdominal surgical emergency, and it represents about 10,000 pediatric hospitalizations per year in Canada. Um, but despite how common this disease is, there's still a wide variation in clinical presentations and in outcomes reported in the literature. And we think that this has to do with the fact that often appendicitis is oversimplified into two categories, simple and complicated, when in fact there's probably more granularity and variation among cases. Um, there is no reliable, widely validated grading score that appropriately risk stratifies pediatric appendicitis, and I'll get into that a little bit in a moment. So again, there's this fallacy of simple versus perforated. And it's like if I told you, it's raining or it's not. Well, obviously, if you're in the middle of a tropical storm and your roof is being ripped off of your head with, 200 miles per hour wind, you would qualify that as a little bit more than just it's raining. And it's kind of the same idea with perforated appendicitis. You know, Traditionally, appendicitis has been qualified as either simple or perforated. But surgeons who deal with appendicitis understand that that's a very gross oversimplification of the disease. And in fact, there's degrees of severity of perforated appendicitis with associated findings at the time of surgery. We're used to this in surgery. We have different classification systems that exist. The one shown on the left of the screen is the Hinchey classification for perforated diverticulitis. It was actually pioneered at McGill by Dr. Hinchey and is still used today to essentially qualify the severity of the perforated appendicitis and predict outcomes. It's both clinically useful and useful for research. The AAST, the American Association for the Surgery of Trauma and Emergency General Surgery, developed a grading system for acute appendicitis in adults, which is very interesting and actually significantly mimics the perforated appendicitis, the pediatric appendicitis grade that was developed here specifically for pediatric appendicitis. So there's definitely a recognition in the literature that we need better tools to risk stratify appendicitis to have a better understanding of the impact on outcomes and health resource utilization. This was kind of the driving motivation behind this multi-center study that Dr. Emil is the PI of. It's called the Pediatric Appendicitis Grade Evaluation Study, or the PAGE study. And this study has been selected by CANCOR, which is a Canadian Consortium for Research in Pediatric Surgery, as one of the ongoing studies. And there was an effort to get some more significant CIHR funding, which was unsuccessful in the first trial, but we're resubmitting, and hopefully we can get this study really off the ground. The idea of this is that actually through primarily retrospective research, the team here at the Montreal Children's Hospital, again, led by Dr. Emil, and by Dr. Yasmin Youssef, did a very significant amount of work to define subcategories of perforated appendicitis and then correlate those prospectively with clinical outcomes and resource utilization. This paper was very widely cited, actually, and was selected as one of the top papers by the APSA Committee on Publications because of how useful it is. And this is a summary table on the right that I just oversimplified because the table in the paper is a bit crowded. But what these are the outcomes that were significantly different by grade, and I'll explain to you a little bit more about the grades. So in this initial iteration, the grades went from 1 to 4. So grade 1 was just a localized or very contained perforation. You can imagine, for those of you who have been in the OR at the time of an appendectomy, you can I imagine a little bit of contamination with basically the omentum sealing it off. but no large abscess and no diffuse peritonitis, no pus throughout the abdomen or anything like that. A grade 2 is basically a patient who has a contained abscess. So the abscess in this study was defined as a collection of fluid, of pus, into which you break into during the surgery. So again, this is an intraoperative grading system. It's only allocated based on the surgeon's intraoperative assessment. And so it's a dynamic thing to assess. A grade 3 is a patient who has generalized fibrinopurulent peritonitis, meaning that there's fibrin or pus throughout the abdomen, but that there's no dominant abscess, meaning there's no like isolated fluid collection. And a grade 4 was defined as a combination of 2 and 3, where you have generalized pus throughout the abdomen plus one or more dominant abscesses. And you see that as the grades increase, then many relevant outcomes and health utilization outcomes, so post-op abscess, which is the most common complication after perforated appendicitis surgery, length of stay in days, occurrence of ileus in days, time requiring antibiotics in days, utilization of TPN, and utilization of post-op imaging were all significantly increased with increasing grade. So this pediatric appendicitis grade evaluation study, or the PAGE study, has two major objectives. And the first is to establish the reliability and reproducibility of the pediatric appendicitis grade. As I mentioned, it's an intraoperative surgeon-assigned grade that is based on the intraoperative findings. So the first question that needs to be really answered is, do surgeons agree on the grade? And the question, of whether this is reliable or not came up from my experience in fellowship, where I often found myself reading OR reports and then asking the surgeon to describe what they found in the OR and identifying that there was a discrepancy. And the larger overarching objective is to validate the pediatric appendicitis grade as a predictor of clinical, patient-reported, and health resource utilization outcomes in a large, multi-center prospective cohort study. But for the presentation today, I'm really going to focus on objective 1, because this is the study that I'm conducting with the help of Dr. Ponero and Dr. Emil. As I said, the grade is assigned intraoperatively. So the way that we actually do that is we subdivide the abdominal cavity into 6 spaces: the right upper quadrant / subdiaphragmatic and perihepatic space, the left upper quadrant / left subdiaphragmatic and perisplenic space, the right lower quadrant, which includes the paracolic gutter, the left lower quadrant, which includes the left paracolic gutter, the mid-abdomen, which really is the interloop space as you run the bowel, and finally the pelvis. And in each of those, so there's a sort of a systematic assessment that needs to happen in every surgery in order to assess each of these spaces and look for the presence or absence of pus and or an abscess. We decided, for the purpose of the multi-institutional study, to expand the pediatric appendicitis grade a little bit. So it now includes essentially 6 categories. 0 is a normal appendix. So, it's unexpected to find that in the majority of laparoscopic appendectomies, because we know that our negative appendectomy rate, particularly now with an increased utilization of ultrasound, is much less than 5%, probably more in the order of 0.5 to 1%, if that. And then everything has been shifted up a little bit. So non-perforated acute appendicitis is now grade 1. And then we created a 1G category for gangrenous appendicitis, but that is not perforated. And then the perforated appendicitis categories were shifted to 2 through 5. So 2 is a contained perforation, so equivalent to the previous grade 1. Grade 3 is perforation with a discrete abscess, equivalent to the previous grade 2. Grade 4 is perforation with generalized peritonitis, but no abscess, which is the previous grade 3. And grade 5 is a perforation with an abscess, one or more abscess, and generalized peritonitis. And to date, the study, as designed, includes 17 sites, so all 12 Canadian academic children's hospitals that are part of the CANCOR consortium. And there are also 4 international sites, 2 in the United States, 5 international sites, 2 in the United States, 1 in Brazil, 1 in the UK, and 1 in the Netherlands. So specifically to address objective one, our hypothesis is that the pediatric appendicitis grade has very good inter-rater reliability. In other words, we believe that surgeons will easily be able to differentiate between a grade 2 and a grade 3, or a grade 3 and a grade 4. And the way that we plan to measure inter-rater reliability is with this outcome measure here, ICC, intra-class correlation, which is considered very good when it's greater than 80%. So that's our hypothesis. So what are the methods? Essentially, we will be using attending surgeons and advanced surgical trainees who are PGY4 or greater as raters or observers, and they will be asked to complete a video-based survey and grade cases based on intraoperative footage. And the intra-class correlation will be calculated based on this. So intra-class, there are many different ways of measuring inter-rater reliability, but the intra-class correlation is best suited for this study question because it's ideal for studies with more than 2 observers. And it also accounts for the magnitude of disagreement for ordinal variables. And our contention is that, it's obviously very different if, let's say, surgeon A interprets a video clip as being a grade 2 and surgeon B interprets that as a grade 3 versus surgeon A interpreting video as grade 2 and the other one interpreting as grade 5. And intraclass correlation accounts for the magnitude of disagreement, if there is any. So this is just a bit of an example of how the data would be tabulated. So we refer to the study subjects as the video clips themselves, in fact, because these are the subjects that are being observed, and of which the inter-rater reliability is being measured. So it's a bit confusing, the nomenclature, because you often think that the people are the subjects, but that's not the case in this type of study design. And what we call replicates are actually the individual observers who will be viewing the video clips and providing their grading. And so we can tabulate this into a large table, and then the statistical software can generate the value for the ICC, which will vary between 0 and 1. 0 being no correlation at all, and 1 being perfect correlation. So how do we calculate sample size for a study like this? Well, you have to put in a few assumptions. Assumption 1 is, what is the minimum acceptable reliability for ICC for this, for what we're measuring, which is our grade. We decided that we would use a minimum acceptable reliability of 70%, which is considered more than adequate, but sort of not very good. So it's kind of somewhere in the good range. Assumption 2 is, what is our expected reliability? So our hypothesis was greater than 80% ICC. So our expectation is that it's going to hit 90%. And, we're looking for a significance level of 0.05, a power of 80%. And we're being very pessimistic, I think, in our sample size calculation to ensure that we have enough subjects. But we're assuming that only 2 people per study site will actually participate in the study and provide us with their measurements, where in fact we are drawing from a much larger pool. So we're estimating about 34 observers. And with those parameters, the minimum sample size of subjects, so the minimum number of video clips that we need to expose the observers to in order to assess whether they can truly differentiate one from the other, is 25. Which comes out to about 3 to 4 video clips per level of the grading system. So in terms of recording the surgical footage, as part of our local IRB for this study, we got authorization to seek consent from consecutive pediatric patients with perforated appendicitis at the Children's Hospital. Were consented for intraoperative video capture, and this was carried out between January and July 2023. And we were able to collect a good number of cases of footage. You can see we had a lot more simple appendicitis than we realized, so grade 1. But we have, at least 4 in each of the categories of perforated appendicitis. And this is just to give you guys an example of some edited footage. So this is a grade 4 case. So a patient who has perforated appendicitis with generalized purulent peritonitis, but no discrete abscess. So we're viewing here pus along the paracolic gutter on the left side, pus in the pelvis near the cecum, fibrin deposits around the appendix, and again, viewing the pelvis with the gynecological organs there. So this is just an example of the type of footage that we collected. And you can see that it can be edited together into a short clip that really just highlights the different regions of the abdominal cavity that we discussed previously, so that the people observing the video can, make a fair determination of what the grade should be. So that's one example. Here's another example. This is a, oh, sorry, that's, I'm gonna go to the next one. Right, so this is a grade 5. So just to give you, for those of you who've never been there, it's a much more severe view because you have basically multiple abscesses between the loops of bowel. Everything is more stuck together. And in addition to that, you have these large pools of pus throughout the abdomen, like you did on the last video as well. So a bit more significant, and soon you're going to see the surgeon sort of pop into an abscess there, and so that's sort of how we define those things. All right, so our idea was then to take this raw footage, edit it all together into different clips that are about 2 minutes each. Obviously, we don't want it to be too burdensome for the observers. We think that would hinder appropriate data collection. And the idea was to include the videos in sort of a survey like this that could be distributed. So there would be, a quick consent page and basically a reminder of what the appendicitis grade is with the definitions that people could refresh their memory. And then we would go on and show them videos. Unfortunately, the tests that I was performing with the Microsoft Forms allowed me to embed YouTube videos, but they were categorized as age restricted by YouTube's algorithm because I guess pus is gross. And unfortunately, that's an issue that I still have to work on. But you would, as a responder, you would basically receive this survey. You would watch each video and then have an opportunity to grade it. And then at the end, you could provide any comments or feedback. So we also thought that this was a good opportunity to really educate broadly across Canada, all of the pediatric surgical providers that we are in touch with. And so we decided, in fact, to compile the most illustrative videos into an annotated instructional video to really illustrate each grade, and by providing video annotations and voiceover commentary that would really strengthen the learning about the pediatric appendicitis grade. And then we were thinking that we would then allow a washout period to occur. So this instructional video would be distributed following the first round, or what we're calling the pre-test or the baseline assessment. Then we would give the instructional video. We would allow about a 1 month washout period, and then we would send the survey again for people to regrade the same set of videos and see if this provides any improvement in our reliability measurement. So just to give you the 30,000-foot view, this is sort of the study timeline. There's 3 major phases: the preparation phase, phase 1, which is the baseline assessment, and phase 2, which will be the final assessment. And we're currently still in phase 1, really. We've successfully completed raw footage collection and are in the process of editing the videos, but that has not been completed yet. I went through an initial round of basically time-stamping the videos and assigning labels, and Dr. Emil still has to review it. And then we're going to be submitting it all to a professional video editor. So hopefully by end of calendar year, we'll have completed this phase. As soon as these videos are complete, we'll be able to put them in the survey and distribute it and allow a few weeks for people to respond. So we're hoping by February 1st of next year, phase 1 will be completed. Following this, we want to send out the instructional video allow for the 1 month washout period, and then run the survey again over a period of 3 to 4 weeks, which would bring us to about April. At this point, we would have all the data for the pre and the post. So this would give us time to basically analyze our data, write an abstract, and hopefully submit it. We were targeting the Society of Academic Surgeons, which the deadline is in August. So that's sort of a good goal we're working with. So, and hopefully by next fall, the manuscript will be complete and submitted. So that's pretty much it in terms of what I wanted to present to you today. So I'll stop sharing so that I can see your faces and answer your questions.